Okay, Madan.
Yes, sir. Prerak, everything is ready. We are starting. Prerak?
1 second, sir. 1 second. It's
Yes,
getting
yes.
live.
Yeah.
We are live now. So,
Yes.
welcome all of you to all the doctors and delegates to this very much informative session organized by Association of Maharashtra Obs and Gynec Society along with Bihar Gynec and Obs Society, supported by Corona Remedies to the Core Connect Live webinar. First of all, I would like to introduce two of our conveyors. First is our Dr. Kamble, who is a National Coordinator of FOXI Sexual Health and STI Committee, Zonal Coordinator AMOGS, and Dr. Prerna, who is a National Coordinator FOXI and YTP Committee. So let me introduce first Mr. Dr. Kamble, who is the Zonal Coordinator of AMOGS Zone 4 from 2026 to 2028 and also the chairperson of AMOGS Sexual
You can
Medicine.
leave this. You can leave both the coordinators. CD, please move
Yes.
ahead. Hand it over to Madan.
Yeah. So,
Yeah.
Dr. Sir.
No, it's okay. It's okay. Thank you. Good evening, everyone. Myself, Dr. Madan Kamble. I welcome you all for this
You're self-employed.
special webinar, which is planned.
Salaried या फिर self-employed?
Self-employed कर दो.
Yeah.
हाँ तो salaried जो अभी अब salary तो है ही
Prerak,
नहीं.
Prerak, you can mute.
पेंशन आता है.
Okay. Sorry. AMOGS is privileged to welcome all the esteemed dignitaries for this webinar, and also all the seniors, all the presidents, secretaries, and the delegates of Obstetric and Gynec societies of Bihar and Jarkhand. We are very happy to connect with all the societies of Bihar and Jarkhand. Actually, AMOGS is conducting serial programs and trying to connect with all the FOXI societies through this series of webinars for the awareness of psychosexual health and all about the obstetrics and gynecology. With the blessings of AMOGS office bearers, respected President Dr. Ame Purandare sir, Honorary Secretary Dr. Rohan Palsetkar, and all the executive members of AMOGS. Today we are so honored to have the chief guest, our own Dr. Ame Purandare sir, and respected Abharani Sinha ma'am, who is the Vice President East Zone currently, and also the esteemed guest of honors, the senior most respected sir, Dr. Alok Devdas sir, Dr. Anita Singh madam, and Dr. Vinita Singh madam from Patna. And also the special guest from Bihar and Jharkhand, Dr. Archana Kumari madam, Dr. Suman Sinha madam, and Dr. Nibha Mohan madam. These three are the current FOXI chairpersons from Bihar and Jharkhand. I also welcome Dr. Pragya Mishra madam as a speaker, Dr. Apurv Datta as a speaker, all the chairpersons of all the sessions, and experts as for the panel, Dr. Supriya Jaiswal madam, past chairperson of Adolescent Health Committee FOXI, and Dr. Pratibha Singh madam, past chairperson FOXI IAEC committee, and although esteemed panelists for the wonderful session. So in this session today, we are having two talks and one panel, very important clinically related topics. First, I would invite all the dignitaries to join the lamp lightning. Next slide. Yes. Thank you so much. Now it is honored to welcome our chief guest, Dr. Amey Purandare sir. Actually, no need to introduction for this person. He is a very humble, very active and supporting person who is the president of AMOGS. We all love Amey sir, and Amey sir loves AMOGS, and he is very supportive to each and every member of AMOGS. And I would like to say something about Amey sir. This is actually Amey sir's dream and initiative, uh, that AMOGS should, there should be a unity between AMOGS and all the societies of Bihar and Jarkhand. So Amesar is trying very much for that, and that's why we are trying to connect with all the societies of Bihar and Jarkhand, and also all other states also. So AMOGS is happy to connect with you all, and I welcome Amesar for your blessings. Over to you, sir.
Yeah, thank you, Madan, for those kind words. I hope I am audible to everybody.
Yes, sir.
Yeah. It gives me great pleasure to be here this evening for this webinar of AMOGS in association with our two dear society friends, namely Bihar and Jarkhand societies. We believe at AMOGS that the more we collaborate, the more our members will benefit from each other's experiences and each other's point of view. With this, our knowledge will definitely amplify, but it will translate into better and more positive outcomes for our patients. It gives me great pleasure to share the screen with someone that I really admire and I really respect my friendship with her, that is Dr. Abharani Sinha. My connect with her goes back to the quiz committee of Foxy, and she has always blessed me to rise higher and higher in my professional career in various organizations. So, thank you, madam, for gracing this occasion. Also, I am really happy that in this webinar, we have the presence of the highly academic and knowledgeable and respected Dr. Devdas, who has been the past ICOG chair and also the past vice president of Foxy. And sir has given his lifetime for the benefit of maternal and fetal well-being. Thank you so much, sir. Two senior members of Foxy from Bihar, namely Dr. Anita Singh and Dr. Vinita Singh, are also here as chief guests, and I'm thankful that they have also consented to be a part of this webinar. Also, I must mention the faculty for today, namely Dr. Pragya Mishra, Dr. Apurva, and our moderators as well as conveners, Dr. Madan Kamble and Dr. Prajna Keshan, who have done a great work in this, in the ideation, curation, as well as the execution of this webinar series. We are also blessed to have the experts in the form of Dr. Supriya Jaiswal and Dr. Pratibha Singh, both past chairpersons of Foxy committees. And to chair the sessions, we have none other than Dr. Moshmi Das Ghosh, Dr. Meeta Sinha, Dr. Kumudini Jha, and Dr. Lakshmi Sen. We must also keep in mind that our special guests are the three Murti from Bihar in the Foxy Managing Committee, namely Dr. Archana Singh, Dr. Neha Singh, and Dr. Niba Mohan. So once again, I welcome all of you. The topics chosen are extremely practical, informative, and out of the box. Congratulations, Madan and Prerna, once again for having selected such important topics. Last but not the least, I wish all the delegates happy learning, and I'm sure that you will benefit from this academic exchange between AMOGS and the Bihar and Jharkhand societies. So long live AMOGS, long live Bihar and Jharkhand societies, and hope that our mothers and our fetuses come up to be happy and healthy, and India progresses from strength to strength. Thank you once again.
Yes, thank you, Amey sir, for your kind words and blessings for this webinar. And this is surely strengthen the relations between AMOGS and all the Bihar Jarkhand societies on every platform. Thank you so much, sir. Our next guest of honor, Madam Abharani Sinha, is currently Vice President, East Zone. Madam is so humble and lovely lady, very down to earth, very knowledgeable and active Foxian. I welcome ma'am for this AMOGS platform, and we are very eager to listen you for your words of wisdom. Over to you, ma'am.
Thank you, Dr. Madan. It is indeed a pleasure to be a part of this wonderful webinar, which has been organized by Association of Maharashtra Ops and Gynae Societies, along with the societies of Bihar and Jarkhand. And thank you, Ameya. Thank you for speaking such good words for me. I think we have grown together in Foxy, and I'm so happy to see you in the National Office Bearer team. And you are doing so well. All my good wishes are for you. And I hope you'll also take AMOGS to greater heights. And it's always a pleasure to meet Dr. Alok Devdas, sir. He is an inspiration for all of us. He is highly academic and is very good. And of course, he's a very good singer and a poet also. So sir has so many qualities. And I'm happy to see my senior, Dr. Anita Singh, madam, who is the guest of honor, and Dr. Vinita Singh, who has been elected as Vice President Foxy for the year 28. And the special guests, they're all very close to me from Jarkhand, Dr. Suman Sinha and Dr. Archana Kumari, and Nibha Mohan from Bihar. And we have two brilliant speakers today, Dr. Pragya Mishra Chaudhary, who will be talking on CIN in postmenopausal women, and Dr. Apurva Datta, who will be talking on sexuality and menopause, and a panel which is moderated by our two lovely conveners, Dr. Predna and Dr. Madan Kamble. And Dr. Supriya is one of the experts for this session, along with Dr. Pratibha Singh. And I'm so happy to see all the president and secretaries of Bihar and Jharkhand. I can see all the 5 Jharkhand Society president and secretaries, Dhanbad, Bokaro, Ranchi, Jamshedpur, and Devghar. Arpita is also there. Then I can see Sunita, Manjudi, and then Sudha, I can see from Bihar. The Purnia Society has also joined, along with the Bhagalpur Society. I think they have not joined, but Dhanbad Society has joined, Ranchi has joined, Katihar has also joined. So it's so nice to see all of you so actively involved in so much of academics. I think this association will definitely help our members of Bihar and Jharkhand to grow in their academics, to learn, to enhance their knowledge. And once again, I'm extremely thankful to the AMOGS for inviting me to be the chief guest for this very important webinar. Thank you so much, Dr. Amya Purandre, Dr. Rohan Palshetkar, Dr. Madan Kamble, and of course, convener Dr. Predna Kishan. Thank you so much.
Thank you,
Thank you
madam.
so much. Yeah, thank you so much, Abha. Yes, over to you, Prerna.
Thank you, madam, for your kind words. And it's such a pleasure to have you around. And we look up to you for so many things. You're such a darling and such a dear and such a revered Foxian whom every young gynecologist will always look up to for guidance and support. Thank you so much, madam, for being with us. We now move on to our guest of honors. Our first guest of honor is none other than Dr. Alok Devdas, sir, the past VP Foxy and past ICOG chairperson. Sir, what to say about Sir is there's a distinct privilege to introduce Sir because he's an illuminary and an illustrious Foxian with unwavering commitment to women's health and the beacon for generations of clinicians. Sir, your presence has conferred so much of immense gravitas to this program. Thank you so much for being here, Sir. Sir, the dais is all yours for your words of wisdom. Alok, Sir.
Sir, you're muted.
Sir, you're muted. Please unmute, Sir. Prerak. Prerak. If you can unmute, Sir.
We have sent the request. He has to accept that.
Sir, kindly unmute yourself, sir.
হ্যালো স্যার কাউকে বলুন আপনার ওই নিচের একটা ইয়ে টিপে দিলে আপনি
Uh, so you have to click on that mic icon, sir. It's on your left side, sir. Uh, till till sir is able to unmute himself, we have Dr. Rohan Palshetkar with us, the Secretary General of AMOGS. Rohan, are you there? Yes.
Yeah, Prerna, I'm there.
Thank you for
He is
joining,
the
and
he is the
we can have
Jamai
your
he is the
inputs.
Welcome,
Jamai
Dr.
Raja
Rohan.
of Bihar and Jarkhand.
Welcome,
He has
Dr.
special
Rohan.
privilege.
Thank you so much. Uh, Again, I just want to say that Madan sir, Prerna, you're doing a fantastic job. Again, I'm going to reiterate what I said at your last webinar. Even though you all both have been elected unopposed, I am so happy to see your enthusiasm to carry out these academic programs and do such a fabulous job with them. And today's topic also, menopause, is fantastic. I think Alok sir's mic has been unmuted. I don't want to take too much time. I want to just wish you all the best. And I'm looking forward to hearing the CME as well.
Yes. Thank you, Rohan.
Thank you, Rohan.
Yes.
Alok sir, we need your blessings, sir.
I will try whether I'm.
We can hear you,
Is
sir.
it? You can hear me?
Yes, sir. Yes, sir.
Oh, that's good. Well, for me, it's a pleasure to meet the current leaders of obstetrics gynae of India, like all of you, because I don't nowadays go to many conferences, not even AICOG, so get less chance to meet all the leaders, and this is a great opportunity. Another thing that I personally think, I don't live in the past, not even in the present. I live in future. So I'm expecting the deliveries from all of you of future of obstetrics gynae in the area that you will be speaking. That how we are progressing or thinking to progress to take us further for with the problems that we have. Well, that's all. And nice to see Amir after a long time. Okay, then thank you, Prerna and Dr. Kumble.
Yes. Thank you, sir. Thank you so
Thank you,
much.
sir. Thank you so much, sir. Thank you for your blessings, sir. Uh, we are always honored to have you around. And we now move on to our next guest of honor, Dr. Anita Singh, madam. I don't think Anita Singh, madam, have logged in. Dr. Madan, has she logged in? Can you see? If in case she logs in late, madam.
Not able to see. Even Dr. Vinita ma'am is also busy in OT. She will join
In
later.
case they log in later, we can take their blessings. We are really honored to have their consent for this web meeting, and their mere consent is also a blessing for us, and we can definitely move ahead with that. And we have our special guests, Dr. Archana Kumari, madam, Dr. Suban Sinha, madam, and Dr. Nibha Mohan, madam, who are the present sitting chairs for Foxy. And we are really glad to have so many chairpersons in Foxy through the East. We also have logged in Dr. Supriya Jaiswal, madam, who is the immediate past chairperson of Adolescent Health Committee, and so many of our dignitaries with us. Without much ado, we can start with our scientific sessions, and I humbly again extend my earnest gratitude to each and every dignitary who have joined in to make this eloquent program a success. Dr. Madan, over to you.
Yes. Once again, thank you all the presidents and secretaries and all the seniors for supporting both of us in the nominations and making us unopposed, elected unopposed. Thank you so much. Yeah. Now we will move on to the scientific session. Yeah. Prerak? Yes. First session is on CIN in postmenopausal women. And for that, we are having esteemed chairpersons, Dr. Sunita Jha, madam, who is the
I'll just
president.
call Pragya, madam, because she asked me to call just 2 minutes prior.
No,
You can
Pragya
introduce
madam
the
is joined.
chairpersons by then. Pragya, madam, is there?
Yeah,
Okay,
Pragya
fine.
madam is there. The
Fine.
second chairperson is Dr. Komal Singh, ma'am, who is the president of Dhanbad OBGYN Society. And third chairperson, ma'am, Dr. Arpita Gandhi, madam, who is the president of Devghar OBGY Society. I welcome all the chairpersons for this particular session, and I hand over to chairpersons for further proceedings. I request chairpersons to welcome our speaker, Dr. Pragya, ma'am.
Hello,
Yes.
Pragya. Dr. Pragya Mishra. She needs no introduction. To me, I had seen her when she joined as an intern in our unit when I was a PG. She was then just a Barbie doll. And she is like my younger sister till now. She is MRCOG, FRCOG, PhD, DFFP, FICOG, Diploma in Gynec Endoscopy from Kiel, Germany, FSUG. She is now President Patna Obs and Gynec Society 2025 to 2026. She is immediate past Secretary General ISOPAR 2022 to 2026. If I will go on reading her awards and her positions, I am very sure that we will miss her lecture. And I am again telling you that she needs no introduction. Now I welcome you. I welcome Dr. Pragya to start her paper CIN in postmenopausal women.
I also welcome Dr. Pragya for a most academician, very affectionate to all the members of Jarkhand and Bihar. Welcome, Dr. Pragya, for your presentation.
One thing I would like to add as a convener for the program is that I called Pragya Madam and she was in the midst of so many meetings. She also has to travel tomorrow to Calcutta for a talk, but then she didn't turn me down. And thank you, Madam, for that commitment, that unwavering commitment towards academics. Thank you so much, Madam, for accepting our request to be here. By the time Pragya Madam joins in, we can have a maybe a 1-minute discussion between our chairpersons regarding menopausal CIN. Yes, yes, Madam. Yes, Madam. Please share your screen, Madam. Pragya Madam.
Is there any problem sharing?
No, she doesn't have a problem sharing. She's there. She's opening it. Arpita Di, anything you want to say regarding? Yes, Pragya Ma'am is here. Ma'am, kindly share your screen.
Should I share my screen?
Yes, Madam. Yes, Madam.
Okay.
Madam, we have done with your introduction and all that.
Yeah.
Yes, Madam. Thank you so much, Madam, for taking out time in spite of your busy schedule, being traveling to Calcutta tomorrow.
But this is a different laptop and I can't find the shared screen. One sec. It's there.
It's just in the bottom, the third option,
No,
share.
I can see, but the moment I'm opening my presentation, then.
Ma'am, you can mail your presentation to Prerak. He can share, Madam. Prerak, send your email ID on the chat box.
Yes, ma'am.
Or you can WhatsApp also, Madam, in the group. He can download and he can share, Madam.
Yeah. I think now you all can see the screen, but I have to.
Yes, Madam, we can see, Madam. You can put it to the slideshow, Madam. The slideshow, madam. You can have it on full screen.
Give me some time.
That cup-shaped thing there, madam, near the finger icon.
It's not that. All that, internet stuff is just coming on.
On the top left corner, madam. Near the finger icon, there is a cup. Yes, madam. Near the finger icon, there is a cup-shaped thing, madam. That will bring it to full screen, madam. The fourth icon on the top left corner, madam. Yes, madam. This side, madam. Left side, madam.
Is it the layout?
Just the finger, the index finger icon is there. That's the fifth icon. The fourth icon is the slide share icon, madam. You can just pull this cursor to the top left corner. Yes, madam. The fourth one. You are putting it the third. The fourth icon, madam. There's a cup-shaped icon with a play button. Yes, madam.
See, Prerna, in mine, full screen is coming now.
Now it is full screen. We are able to see.
Ma'am, you can see your screen, madam.
Yeah, it is full screen.
We can. Yes. It's full, madam. Now it's full, madam. Full screen, madam. You can go ahead, madam.
Yeah. I'm unmuted, right?
Yes, madam. We can hear you, madam.
Yeah, okay. So a very good evening to all of you. At the outset, I would like to thank AMOGS, All Maharashtra OBS and Gynae Association, especially Amir Purandare and Rohan Palshetkar, and the two dynamic conveners, Dr. Madan Kamble and Dr. Prerna Keshan, for this opportunity. And my regards to Dr. Devdas and other guests of honors, Dr. Anita Singh and Chief Guest, Dr. Abharani Sinha and Dr. Amay Purandare, and guest of honor, Dr. Vinita Singh, Dr. Anita Singh and Dr. A.K. Devdas. So at a very short notice, Prerna told me to speak something on midlife. And so I just, because I do a lot of colposcopy, and I see that women, who are postmenopausal, so usually I see them in so much of distress. I see them because they come with quite persistent discharges and foul-smelling discharges in so much agony, and people have prescribed courses and courses of antibiotics to these women without really diagnosing what the problem is. So I just thought, why not speak on this aspect, cervical intraepithelial neoplasia in postmenopausal women. Yeah. So cervical cytology and colposcopic assessment of the cervix, as you know, that they are both complementary to an accurate diagnosis of CIN, and there are specific problems in the postmenopausal age group. At what happens that at presentation, generally these older women tend to have more advanced lesions such as CIN3, microinvasive or even frank invasive carcinoma. And we all know that a woman spends 1/3 of her life in menopause. And because of the aging population, more postmenopausal women are presenting for routine medical care. And in fact, studies have shown that even in this age group, the incidence of abnormalities
cervical in screening or colposcopy, it's almost up to 6.5 to 8%. So the upper age limit of cervical screening, according to WHO, it's 65 years. Well, some reports have been from other countries where they say you can stop at 50 years, but mostly it's 60, 64 years generally. But for us, or even it's about 65 years. So postmenopausal period is characterized by tranquility in gonadal activity, but however, there is variable function of the adrenal cortex, which is the third gonad, and there is persistence of some ovarian activity leading to different degrees of epithelial maturation. So postmenopausal cell patterns, on cytology, what we can get, because even every gynecologist should have some basic idea of cytology as well, because, when they come to us with the reports, they could come with an atrophic smear, or they could come with an intermediate, which is like an androgenic smear, and a superficial or an estrogenic smear. So the peripheral effects are exerted by hormones on the vaginal mucosa, and which can actually give us an idea of the reliable hormone status. Reason is that measurements of circulating hormones are just a temporary determination of a changing quality. So when you look at an atrophic smear, what does it mean? We mostly get basal and parabasal cells with mixed bacterial flora, and it can be with a dirty background of cellular fragments and polymorphs. You can see in the picture, mostly like basal and parabasal cells. And suppose, or you can get a smear with intermediate or androgenic, which is like mostly you would find basal to intermediate type of cells, singly or accompanied with polymorphs, or superficial smears where largely solitary and flattened superficial cells with the rare leukocytes. But then, beware of superficial cells in a postmenopausal women, because normally, ideally, we should not be getting that kind of a smear in that age group, because if it is there, it sort of alarms us to go for something more like an endometrial biopsy for these women, because a superficial smear is more like an estrogenic smear, and intermediate or androgenic smears are because of the effect of progesterone and androgens. Now, the advantages are that if you get an atrophic smear, you can actually think of administering you can think of administering appropriate HRT and assess the effects of HRT, and eventually, if the smears come back to normal, or later on when I talk more about colposcopy, you would understand it better, then you can actually stop the HRT. Now, superficial smears, as I just mentioned, they need additional diagnostic evaluation and avoid a useless or even dangerous HRT, which is not needed for these women. Now, common cytological features in older women, what happens that there is poor cellular exfoliation, there could be cell clumping and air drying artifacts, then endocervical glandular cells are often absent, there can be an inflammatory background, because of the atrophic cervicitis, vaginitis, the nuclear pycnosis, which is nuclear shrinkage, and karyohexis, that is nuclear fragmentation, then reduced cytoplasm, giving rise to increased nuclear cytoplasmic ratio. So what happens that all of this, like, the common cytological features in older women, that creates difficulty for the cytologist to assess the smear and identify dyskaryosis. Now, colposcopy in the menopausal women, because of the estrogen laws, that leads to changes. And what are these changes? The squamocolumnar junction it recedes up the endocervical canal, and there is increased chance of not visualizing the SCJ. There is thinning of the epithelium, so you have to be very gentle with these women when you do colposcopy. There can be punctations or unusual vessel patterns. Then reaction to iodine is often incomplete because of poor glycogenation. And then reaction to acetic acid also, it can be a false positive because of the stripping. So, colposcopy, doing colposcopy and interpreting colposcopy in menopausal women, one really has to be very careful. Now, what are the common senile atrophic features on colposcopy? Just to elaborate, like, as you can see in the picture, the squamous epithelium is very thin, hence easily traumatized. If you're not gentle, these women, they just start bleeding very easily. Then the glandular epithelium is smooth and the papillae are red, like the ones that you would find the columnar epithelium, the papillae of columnar epithelium in younger women, you would not find in these postmenopausal women. The transformation zone is less likely to be visualized in its entirety. Like, as you can see in these pictures, the transformation zone or the squamocolumnar junction has receded inside the endocervical canal. And then you can see subepithelial petechiae, on the right side, and typical, like strawberry cervix that one gets in the postmenopausal age group. So very nicely, you can see the strawberry cervix on the right side. Now, the cervix looks very pale, which is hardly affected by the application of acetic acid. Like, on the left side, you can see a very pale looking cervix because of lack of estrogen. And when you apply Lugol's iodine, it results in a pale yellow staining. And that is again because of lack of glycogen. On the right side, as you can see, there's just partial iodine uptake. And you get a leopard skin appearance in these women. So two features, like, a strawberry cervix and a leopard skin appearance. Now this was from a patient, who kept on having vaginal discharge and persistent vaginal discharge, where she had been administered several courses of antibiotics with no relief. And basically, well, it just looked like an atrophic, all atrophic changes in the cervix. And a course of about 3 months of Premarin or Evalon cream, it actually helped her a lot. When you call them after 6 months, you would see a beautiful cervix, which has actually taken up the iodine and looks a lot better. And the patients, they really thank you for it, because so far the diagnosis had not been made and people had been administering different kinds of drugs and creams for them. Another picture from a postmenopausal woman. On top, you can see, like, on the left side, you can see a strawberry cervix, and exactly, in those areas, you can see that the iodine has not been taken up, on the right side. So these are the areas which which lack glycogen, and because of that, it has not taken up iodine. So atypical epithelium in these women, what happens that even the epithelia, it takes longer to be demonstrated after application of 3% acetic acid. Now, when I'm talking about 3% acetic acid, like, never apply 5% acetic acid to a woman who is postmenopausal, because, it literally burns. They get a severe sensation of burning. So always, for a woman who stopped her periods, or that she's postmenopausal, always go for application of 3% acetic acid. So preliminary saline and green filter techniques strongly recommended, because they are demonstrative of atypical vasculature in all cases. Now, the stromal vessels, they appear more prominent, and they resemble atypical vessels and punctations. So that's another problem in these postmenopausal women, that one gets a false picture of an abnormal transformation zone, but it's basically because the epithelium is thin and because of the petechiae, which resemble which resemble abnormal epithelium. Now, so some more pictures from women in this age group. Like you can see, basically these are all pictures of atrophic changes and not really abnormal transformation zone, because you can see petechiae and all that, but don't make a right, don't make the wrong diagnosis by thinking that it's an abnormal cervix. Now, again, inversion of the transformation zone into the endocervical canal, that happens in approximately 60% of patients in greater than 50 years age group. As you can see in all these pictures that the SCJ has receded, it's gone up into the endocervical canal. Now, presence of estrogen, and there is presence of estrogen and progesterone receptors in the cervical epithelium, and this the endogenous estrogen or exogenous, because of the effect of estrogen, usually when women are younger, there is increased cervical volume, and because of hypertrophy of the fibromuscular stroma, edema, and vascularity, there is inversion of the endocervical canal and transformation zone, and all that doesn't happen in the postmenopausal age group. So what do we do? Like so if you want to do colposcopy in a woman who is in the postmenopausal age group and you can't see the squamocolumnar junction, you can give her short-term estrogen, like either systemic or topical. We can give her estradiol valerate to like 2 milligrams daily for 2 weeks, or conjugated equine estrogen 1.25 micrograms daily for 2 weeks. And colposcopy should be carried out on the last day of treatment. And short-term administration of unopposed estrogen is quite safe, because people wonder whether you can give it to these women. It does not cause endometrial bleeding when treatment is stopped. So after estrogen replacement, you repeat the colposcopy. Biopsies also you can you should take if you're not sure of the diagnosis, and if you're doing a conization, you have to include the squamocolumnar junction. And as I said that, you know, and really if you can't see the SCJ, and if you're suspicious of an abnormality, or the cytology has shown superficial squamous cells, then one would go for an endometrial assessment. That is, if you don't see basal and parabasal cells in cytology of a postmenopausal woman. So good quality biopsy from the postmenopausal cervix can be difficult. These are some of the biopsy forceps that we use. Tischler-Morgan biopsy forceps, which is used most commonly. Then we have the Pozzi-Palmer forceps, small hooks. Then we have rectangular diathermy loops, which are small in size and good for these women. So, like reasons for colposcopy, failing to identify high-grade dysplasia and invasive carcinoma. A reason is that because there is difficulty in, sometimes, you know, it's very difficult, it's quite difficult to visualize the cervix also. It would have really gone up and you have to bend down and really get the cervix into focus. So there can be difficulties. You can traumatize, leading to presence of blood. Then, and you could, as I mentioned, inability to visualize the transformation zone completely, then misinterpretation of the lesion because of the changes that occur in postmenopausal women, then reliance on changes such as atypical vessels, then so these are some of the reasons why colposcopy fails to identify high-grade dysplasia and invasive carcinoma in these age groups. Then histology also, postmenopausal squamous epithelium is thinner with the loss of glycogen. Then it lacks differentiation with little or no surface epithelium, consists mainly of basal and parabasal type cells, and absent or sparse small stromal papillae, often a subepithelial infiltrate then often shows lifting and stripping from the underlying stroma. So histology can will present with more or less these features. So we really, even as gynecologists, we should be aware of, we should have a broad idea of what a cervical smear or colposcopy or a histology would look like in a postmenopausal women, so that we don't make the wrong diagnosis, and that's the main reason that we should be apprised of all the changes that occur in this age group. So and then on histology, one could find reserve cell hyperplasia, basal cell hyperplasia, then dark small cells, they replace the full thickness of the epithelium, which could be misdiagnosed as CIN3. I showed a picture in one of my initial slides of the cytology picture. Then grading can be difficult or impossible. And you must have noticed many a times, they are just unable to give you the correct diagnosis or a definite diagnosis. And there can be excessive hyperkeratosis also on a histological tissue of postmenopausal women. Then treatment, again, I think I'm almost coming to the end. Same principles apply as in younger women, local destructive therapy. But when you do go for a local destructive therapy like a thermocoagulation, which is the latest these days and quite effective, but however, the transformation zone must be visualized in its entirety. Then if there is a need, one should take sufficient biopsies. Then let's if you're it's limited and relatively it's non-mutilating, which is a large loop excision of the transformation zone, and histological examination of the entire lesion is very important. So one has to send the complete specimen after LETS. Then there can be, if there is recurrence or persistence of cytological abnormality, then again, one has to go back and look at the size of the lesion, the histological status of the excision margins, whether it was complete or not, then the grade of CIN, because with the higher lesions, there can be recurrence or persistence, then hormonal status of the patient, because there is statistically significant association between postmenopausal status and histological report of incomplete excision of CIN1, a CIN at the endocervical margin. So all these things we have to bear in mind. And ultimately, well, hysterectomy is hysterectomy, but mostly for other gynecological pathology and not for CIN. So preoperative colposcopic assessment, however, before hysterectomy is a must. Some patients, they ask that, Madam, if I'm going for a hysterectomy, why do I need this? Well, that's to exclude the possibility of invasive disease and also to identify 4% of women with the transformation zone extending onto the vaginal wall, because many a times you would see when patients come after hysterectomy and with some sort of problem like bleeding, and when you do colposcopy of the walls, then that turns out to be normal. So post-hysterectomy problem of vaginal intraepithelial neoplasia can be there in the vaginal wall scar. So that's why it would always be good to do a colposcopy prior to going for a hysterectomy if you are suspecting any cervical abnormality. So I think that brings me to my last slide, and I just wanted it to be brief because I knew it was evening time. Didn't want to take much of your time either as well. So thank you so much for a patient listening, and thank you Prerna and Dr. Madan Kamble once again for this opportunity. I'm quite happy to answer any questions if people have.
Thank you so much, Madam, for that extremely elaborate, exhaustive, and quite an informative and very enlightening talk on CIN in postmenopausal women. It's such an honor to hear you speak. It's always a treat to the ears. We are so very honored to have you amongst us, Madam. Over to the chairpersons for their expert inputs. Sunita Jha madam and Arpita madam.
Thank you, Dr. Pragya. It's again Dr. Pragya's talk, as usual, very informative. And it is a information for all those who are not doing colposcopy regularly. She has given, ma'am, you have given us each and every step, and so that the no woman can be missed for any other than CIN if it's increasing. So very informative, very elaborative, and thank you, madam. It's a very nice to listen you. Thank you.
Pragya, your talk was really, really very brilliant. You have touched almost all aspects. My only 2-3 questions are, when the transformation zone or the squamocolumnar junction is not visible, and we are there is nothing abnormal. So in that condition, can we postpone the examination and can we give her some estrogen cream so that the squamocolumnar junction comes a little bit and we can see it properly?
That is ideal. I mentioned in one of my slides that you can give her 2 weeks of ethinyl estradiol or conjuga ethinyl, that's Proganova or Estrabet or something. Sorry to take the trade names, but can't help it. And then, like, Evalon cream or Premarin cream. Also, you can give for 2 weeks and then call her back. That can be done. But one more thing, a lot number of times it happens that even though you would actually manage to see the SCJ with difficulty, and sort of you can make out quite well that it's a case of atrophic cervicitis, because typically they come with quite with foul-smelling vaginal discharge, and you can give this Premarin or Evalon cream also for short course, like daily for 3 weeks, and that also helps. I mean, you can call her back, you can see, or you can continue also twice weekly up to 3 months. So just to take a look, like alarmingly different picture. You would find, one patient who has not taken up iodine at all, and after 3 months, beautiful uptake of iodine. And the patient is so relieved also, and she would really thank you for it, because no one else had made the diagnosis so far, and people had been giving her, like, vaginal tablets containing clindamycin and fluconazole, etc., and oral medication also like metronidazole, and it doesn't help because it's mostly non-infective 7 or 8 out of 10 times. So what helps is, like Premarin or an Evalon cream for about 3 months.
Thank you, Pragya.
But yes, always never presume that it's because of atrophic changes. There can be abnormalities as well. And but for people who are doing colposcopy, they would have actually they would be competent enough to really judge where a biopsy is needed or an endometrial sampling is needed.
Thank you, madam. If we don't have any other questions, we can, Supradi, you want to add something to this? We can move on.
Yeah, we can move ahead.
We can move on to our next session. We are really thankful to Pragya madam, but in spite of a very, very busy schedule, madam has consented to be with us. And madam, your talk was quite illuminating and inspiring as always. And this deliberation have opened so much of insightful perspective in the field of CIN in menopausal women. Thank you so much, madam, for being with us. We really thank you from the deepest core of our heart. Thank you, madam. Can we move on to the next session, Dr. Madan?
Yes. Yes. For the next session, we are having the esteemed team of chairpersons. Dr. Maushmi Das Ghosh, who is the president of Jamshedpur Society. Dr. Meeta Sinha, madam, who is the president of Bokaro Society. Dr. Kumudini Jha ma'am, with the President of Darbhanga Society, and Dr. Lakshmi Sen ma'am, President of Katihar Society. I welcome all the chairpersons for this session and hand over to chairpersons for to welcome our speaker, Dr. Apurva Datta. Yes.
On basics of a menstrual cycle. And we gave her an oral
Yes.
participation for a cycle. A very good evening to everybody. May I introduce my dear friend, Dr. Apurva?
Yes, ma'am, please.
He's been the winner of the National IMA President Appreciation and in Foxy
Ma'am,
IPAS.
thank you so much, Kumudni ma'am. It's always being honor that you introduce me, and it's मेरा घर है अपना. Everybody knows each other.
Yeah,
Bihar and
that's
Jharkhand is my
true.
no.
That's true.
Yes.
Everyone, you don't need any introduction, but still, people should know what are the credentials that you have. So you have been the Korean awardee in 2024 and International Menopause Society Young Talent Award also you've got. You've been the Young Gynecological Award awardee even by the SEPOG and the Foxy Prabhavati and Dixit Scholarship also you've got. So you have Dr. Vanila Sinha Young Award that I had attended because that was the talk on DNA being taken off from the menstrual blood and for detecting HIV, and you could do it for for stem cell transmission also. So that was a Kamini Rao Award again is another very prestigious one that you've got for yourself, and of course you have been awarded abroad also. So that also I know, and yeah, we are going to hear from you on a very important topic, sexuality in menopause, which is not generally discussed. So we are eager to hear from you, Apurva.
Yes.
Thank you so much, ma'am. Pragya ma'am, it was a wonderful talk. And ma'am, can you please unshare your screen?
Yeah. Thank you.
Yeah. Thank you, Pragya ma'am. Yeah, for wonderful session. I welcome Dr. Apurva. Yeah,
Yes.
youngest champ in the Foxy
So
team.
I brings greetings from the coal capital.
One sec, I would just like to congratulate Dr. Madan Kamble and Dr. Prerna Kishan in advance. Okay.
Thank you so much, ma'am. Thank you for your blessings.
And Madam, Arpita Di had said the right thing for you, the Barbie doll look.
Absolutely.
I didn't hear, sorry.
We always consider Pragya ma'am beauty with brain.
Oh, thank you so much.
No. Good evening, pranam and johar to all. I bring greetings from the coal capital of India, the land of Bhagwan Birsa Munda, Dhanbad. So at the outset, my respect and pranam to all the seniors, all the office bearer, and definitely our guest of honor, very own Alok Devdas sir, Anita ma'am, Vinita ma'am, on all the dear senior. It's been real great to have here. And before I start, I really congrats my friend, my senior Madan sir, who is my partner in crime, and definitely my sister, and you can say my friend Prerna, to unopposed win the elections. Thank you so much, and thank you so much to having me today. So the topic for given me today is very important, and it is actually the menopause and the sexuality. Oh, sorry. So intimacy is not purely physical. It's the act of connecting with a deeper or someone so deeply you feel like you can see you inside your soul. And that is what about the intimacy. Intimacy is not only for the recreation, it is for the procreation. And in any situations, in any cases, when you are dividing your patients or anybody with the intimacy, you are not doing justice to them. And similarly with the menopause. My dear friends, the unfortunate history of the menopause. Menopause, previously known as the deformed male. You can say in 17th centuries, it is defined as the disease. It is defined as the worst of the calamities. Now it is the fraud tell that it is a male dominant theory of the human development. And see the treatment of the menopause, the leeches on the genitalia and the cervix, the cold water on the abdomen, the arsenic, people is died due to the arsenic poisoning, sitting in the hot room and sweat more and more and doing the golf. These are the treatment in the 16th and 17th century of the menopause. Now, this is the list of the RCOG, that is the Royal College of London, where a patient need to be admitted, and you can see the cessation of the menstruation is one of the cause that when the menstruation is cessation in the women, she had to admitted and she needed treatment. So this is was the unfortunate history of the menopause. So what are the symptoms of the menopause now? There may be cyclic changes, there may be hot flushes, there may be tiredness, poor sleep, loss of libido, anxiety, loss of memory, and the dryness, dry vagina, and discomfort or intercourse. Now, why there is a vagina dryness and genital urogenital symptoms of the menopause? Because before menopause the vaginal lining is the thick, it moist, the vaginal wall is flexible, there's a good blood flow in the vagina, and the so when the couple intimate, it actually have giving pleasure to them. But after menopause, what happened? This vaginal lining become thin and dry, and it lose their flexibility, the vaginal blood flow is low, and that's the common symptoms of the dry vagina is the itching, burning sensation, increased frequency of maturation, discomfort, dyspareunia, the light bleeding during the sexual intercourse, tingling and irritation. So it all led to the loss of the interest and loss of the intimacy. So the menopause may cause a lot of changes in the life, and similarly it also changes the intimate life, or in the minor case it may not changes at all. What are the possible causes? As I have already stated, there's a low hormone, so to having intimacy it causes painful. When there is a low hormone, there is a low desire. There will be urogenital symptoms, the lady is getting the hot flushes, and she doesn't want, she wants ki bhai mere ko akela chhod do. Now there's a emotional changes, in the menopause the patient, husband are coming to me, wo bolte hain pata nahi kya ho gaya isko, she is very irritated, she is very frustrated and stressed, I don't know why. It is all due to the hormonal changes, there's a body disfigurement, and this lead to a very negative impact on the interpersonal relationship. So previously it was saying that it is not a medical condition, people are saying it's not a medical emergencies, but nowadays it's really had a very bad impact on the husband wife relationship or a partner relationship. So this also need to be taught, this also need to be discussed, and this also need to be treated, and that's why it's the importance of the menstruation and menopause and the sexuality. So what are the common sexual problems? It is the female sexual arousal interest disorder, female orgasm disorder, and maybe the dyspareunia. So what is the management? Now the first and foremost management is the love, care and tender. The partner should realize that it's not due to कि वो मेरी wife अभी पागल नहीं हुई है, but it's all her hormone who caused this problem to them, and the love care tender from the partner is the one of the major thing which you have to do for the treatment. Now the non-pharmacological, be active. So do the yoga, do whatever you want to lift the mood. You want to go to walk, go walk. You want to dance, you do dance. You do want to do yoga, absolutely do whatever you want. Just be active. Don't smoke. Why so? Because it causes a lot of oxidants, and oxidants further reduces the blood flow to the vagina, and it's lower the effect of the estrogen, and it increases the urogenital symptoms of the menopause. Avoid the drugs and the alcohol. Having more intimacy with the partner, having more hello yeah, having more intimacy with the partner is actually causing help to the patients. Why so? When there is a more intimacy, it increases the blood flow in the vagina, and definitely it causes it causes the less painful. Allow time to being aroused, because due to the hormonal changes they are not much aroused. So whenever we are treating these patients, we always treat as a couple and not as an individual. So these are the non-pharmacological non-pharmacological treatment. Other treatments is the pelvic floor exercises to tighten the pelvic floor. Avoid products which irritate the vagina. For example, Vivas, Intivas, etc., or any strong soaps, because it will make the vagina more dry and will cause the intimacy more painful. So vaginal itching, irritation, it may be the sign of the infection. Self-medication should be avoided. You should meet your doctors and this infection should be treated. Now, vulvovaginal atrophy and associated urogenital symptoms of the menopause, such as vaginal dryness and dyspareunia, should be addressed, and because it affects the quality of life of a couple. Now coming to the couple therapy. So what is couple therapy? Whenever we are coming with any sexual problem, we should treat it as a whole, as a couple, or not as an individual. Talk with your partner. What is your concern? What is the strength of your relationship? What is the weakness of your relationship? Where there is any other health problem like diabetes, hypertension, etc., you should treat them, because this problem, this sexual problem, may be secondary to the hypertension or diabetes, etc. So we have to treat them. If some medicines are there which cause the low arousal, for example, beta blocker, for example, antipsychotic, we have to change those drugs. Many times just changes those drugs and just counseling of the patient, your job is done, and absolutely they have a very good relationship. So we have to ask them what they are feeling, which position is comfortable with you, what time is more comfortable with you, whether it's a night, whether it's a early morning, whether it's a daytime, where you are getting time, where you are getting the free space to each other. Definitely you have to meet. So these are the things you have to ask. Now the STD and the menopause again. So when the patient is in monogamous relationship, it may cause the STD more in the menopause. Why? There is a rearing, tearing will be there. There is a microabrasion due to the loss of the hormone and more friction. So if there is a STD, you should be, very much talk about the STDs and give infection control medicines to them to avoid the STDs. And you also ask them that you can use the barrier so that they can avoid these STDs. So this is the condoms are the best way to prevent the STD, because a man does not need to be ejaculate to give or get more STD. Make sure to put it before the penis touch the vagina, mouth, or anus. So this is very important. Now, now coming to the pharmacotherapy. So what is the main treatment of the pharmacotherapy we gynecologists are using is the local estrogen therapy. So we can use it without any side effect, even where the HRT is contraindicated. This local estrogen therapy is very safe. I have used it at least 1 year regularly without any side effect. Even some person can use it more than 1 year, but its data safety is not available. So you can use the local estrogen therapy at least for 1 year without any side effect. Now coming to the hormonal systemic HRT, that is either you have the HRT or we have the other options is the Tibolone. So it will improve the genitourinary system, symptoms of the menopause. It will improve your other symptoms like the hot flushes, etc. And definitely, and similarly, when the hormone will increases, it will elevate the mood, it will boost the desire, and it will help in the to having the successful intercourse. Now coming to the fluvencerine. So this is what that is the actually the serotonin 1A receptor agonist, and where it is 100 milligram per oral per day. We are using it. Is freely available in India. I am using it is day in day out, and absolutely it is very safe in pregnancy. Very safe in almost every cases. Where it is not associated, it associated with when the patient is in alcohol, because it causes the severe hypertension and syncope. So a patient who is a hypertensive, we should avoid that. And before it start, just do a liver function test and just do a hematocrit level. These two investigations you have to do, and then after you can use in this. Now coming to the testosterone therapy. So what I am testosterone using, we have the patches is available in India. We have a gel is available in India. So gel I am using very oftenly. Just ask them. It is 1% W by W, volume by volume gel is there. So it is just a pinch of the gel in any non-hairy area. Anywhere they can apply. It's not like that they have to apply in the genital region. You can apply anywhere, but it should be the non-hairy area, and definitely it will help it. And I have using it for long 6 months without any side effect. In long term use, yes, you have a side effect like hirsutism, acne, but when you are using judiciously for a short period, definitely it is very helpful. Now, Buspiron. Again, it is available in India. So, what is Buspiron? It is again alpha A partial receptor agonist, and it acts as a anxiolytic. So, it is actually help in the female, arousal interest disorder. And the dose is 5 milligram BD is there, and definitely you can use it. Again, DHEA. Yes, the same DHEA what we are using in the low AMH in the infertility treatment. So, actual dose is 100 milligram per day, but in India it's 100 milligram is not available. 75 milligram is available. I am using it 75 milligram, and definitely it is very helpful. It's also helpful not in a perimenopausal, menopausal, but just like post a bottle, or in the post partum period also, when there is a low desire, definitely it helpful. And I have used it like more than 6 months without any side effects. Now, there are some, over-the-counter medicines like L-arginine. What are these? L-arginine, or you can say many pharma companies are coming and they are saying, yes, you can use it. Basically, these all are the very strong antioxidant. So, when you are giving the antioxidant, so it will increases the blood flow to the vagina. When it increases the blood flow to the vagina, it will remove all the genitourinary symptoms of the menopause, and definitely it will help in the patients. Now, again, the sildenafil or the pink pill. So I am again using it 25 milligram. Again, what the rationale? It increases the blood flow to the female genital organ, and it's a better arousal, sensation, and lubrication. So I have used it 25 milligram OD for 3 months. You can use it, and definitely it's a freely available. One of the major side effect, it has two things. First is the blue halos, and second is the headache. So I always ask them to take it in the night time or the evening time, and you just gave it for the 3 months without any problem. Now, these are the non-surgical vaginal rejuvenation. We have the lasers, we have the PRP, we have a stem cell, we have fillers, we have threads. So we all know now we have a cosmetic gynae. So these are the lasers. So now lasers, what will they? They increases the local blood supply. So it will help in the increases the blood supply. It help and causes the moisturing, and it also help in the tissue remodeling. So by virtue of this, definitely they help in the menopausal symptoms. So these are the different type of lasers. IFM and hypo are there. We have again the PRP, the O shot, G shot, and also in SUI mild to moderate. I am using it day in and day out, and definitely they are very, very helpful, especially in the female orgasm, in female FOD, that is orgasm disorder. Again, the surgical vaginal rejuvenation. So this is again very, very common. We can have wedge rejection, we have vaginal tightening, or the repair of the prolapse. These are the actual pictures you can see when the patients are coming with the lax vagina, and we have doing the vaginoplasty, and definitely it increases boost their confidence, as well as the intimating partner with the husband. So this is again a labioplasty. This is the clitoral hood reductions. And what is the take-home message? The menopause is not the end. The quality, the health, sexual health is important for the quality of life. Female sexual dysfunction is very common. Sexual functioning can be affected by illness, surgery, medication. Assess the medico-psycho-social relationship factor. Simple history taking can do wonder. Treat the cause. Educate about the anatomy and physiology of the genital function. Remove the myths and misconception, and don't treat the patient as an individual. Always treat the couple, because they need the treatment. That's all from my side. Thank you so much for your kind listening.
Thank you, Apurva, for that extremely enlightening, extremely informative, and illuminating and elaborate talk on sexuality and menopause. Over to the chairpersons for the expert inputs.
I think Kumudini ma'am was there previously.
Yes, Lakshmi ma'am, you are muted. Madam, please unmute.
Um,
Yes, Lakshmi ma'am, you can unmute. Yes, madam.
Pranam ma'am, Lakshmi ma'am.
Thankful Dr. Apurva Kumar Datta for your nice talk about sexuality and menopause, which is a now great problem to us because of increasing age of the patient. And you have you have taken all the aspect from both medical and surgical treatment. And also thankful to the Mumbai Obstetric Society for allowing me to sharing this session. Now, thank you all.
Kumudini madam, you're there, madam. Dr. Kumudini Jha,
No,
madam.
I couldn't find ma'am.
Yeah, madam is there, but madam is yeah, madam
Yes,
is there,
yes.
but she's muted.
Okay.
Yeah.
Rina ma'am is there. Rina ma'am
Can
is
you-
our dynamic secretary. Thank you, ma'am.
Hello, Purva. Hello, sir.
Hello, ma'am.
Hello, Madan, sir.
Hello.
I'm there since beginning, sir, but I just now I muted myself.
Okay, madam.
Hello.
Hello,
Thank you,
Prerna.
thank you, and
Hello,
thank you,
hello,
Madan
madam.
sir,
Hello, Rina madam.
and thank
Yes.
you, Prerna, for this wonderful opportunity. Definitely, and we will have fun when you will take over in AICOG Surat. Kumudri ma'am
Thank
is
you,
there.
Looking
Apurva, so
forward.
much.
Pranam ma'am.
Thank you, Apurva, for that wonderful talk. It was very insightful. And as you said, it is all because of the deficiency of the estrogen as well as testosterone, and there's loss of libido. And when you give these, we are giving these estrogens vaginally, as you said, even for a long period without even assessing the endometrial thickness because it doesn't go into the endometrium. It is a local acting thing. So you don't have to bother about it. Of course, you should be sure that there's no malignancy above. And the other thing that you pointed out was that comorbidity should be ruled out because it could be because of the diabetes or the medications they are on. So that is one very important thing that one should consider before starting the treatment because the loss of libido may cause the breaking of the families. And for that, the SRRIs that you said agonists, they are very helpful and especially the rejuvenation. The arginine that causes increase in the blood supply. Hello?
Yes, ma'am, you are
Yes,
audible.
ma'am. You are
Okay.
audible.
Yeah, so the nitric oxide that is liberated by arginine and also by sildenafil, that improves the vascularity and that is why it helps in reducing the dryness. So that is the basic thing. And of course, the G-spot stimulation with all your lasers and all that you're doing is definitely helpful in many patients. Thank you so much for that elaborate and wonderful talk, Apurva.
Thank you, madam,
Thank
for
you
your
so much, ma'am. It's always
Thank you,
great.
madam. Thank you,
Thank you,
Apurva, for
Thank you.
Prerna.
We can move on to
Thank
the
you so
next
Thank you,
much. Thank
session.
you
Prerna,
so
for
much.
having me
Yeah.
here.
Thank you.
Okay.
Thank you,
Supriya ma'am
madam.
ने बीच में ज्वाइन किया था.
Thank you.
Yes. Okay. Okay. Okay.
Okay.
नहीं
Thank you, all
नहीं
the
Hi,
Apurva,
chairperson.
ma'am.
always a pleasure.
Hello, ma'am.
Apurva, always a pleasure,
Yes.
pleasure to hear you, always.
Absolutely same here, ma'am.
And बहुत अच्छा लगा और I was listening. OPD चल रहा है उस बीच बीच में आराम से I'm
I
just
know, ma'am.
watching
Same
and
here.
hearing.
Thank
Thank
you,
you,
ma'am. Thank
Supriya
you
Di,
so much,
for
ma'am.
Bye.
staying from the start.
Yes, ma'am.
I know तुम्हारा है तो कैसे
Absolutely.
नहीं रहेंगे. I have to be there.
Absolutely. Okay, ma'am. Okay. Thank you, ma'am. Thank you so much.
Thanks.
Thank you so much, Prerna. Thank you so much, Madan sir. Okay.
Sure. Let us move on to most awaited session, that is the panel discussion on a wonderful topic, that is psychosexual crisis at midlife. Yeah, okay. Actually, there are so many issues in the midlife. Mostly, maximum are the psychosexual, and that has to be addressed actually properly. That's why we are focusing this topic. For this panel, we have got the eminent experts for Dr. Supriya Jaiswal, Madam, the past chair of Adolescent Health Committee of FOXI, and Dr. Pratibha Singh, Madam, who is the past chair of International Academic Exchange Committee of FOXI. I welcome both the experts and the esteemed team of panelists. Dr. Archana Barik, Madam, who is the Secretary of Jamshedpur Society, Dr. Poonam Sahai, Madam, Secretary of Magad Society, Dr. Reshmi Singh, Madam, Secretary of Ranchi Society, Dr. Reena Burnwal, Secretary of Dhanbad Society, Dr. Anuradha Sinha, Madam, Secretary of Purnia Society, Dr. Prachi Singh, Madam, Secretary of Muzaffarpur Society, Dr. Sudha Jha, Madam, Secretary of Sitamarhi Society, and Dr. Priyanka Rai, Secretary of Devghar Society. I welcome all the esteemed team for this panel, and I welcome my co-moderator, Dr. Prerna. Let us discuss to clear something about what are the issues in midlife, what is meant by crisis, and I think most of the part has been covered by Dr. Apurva. We will more focus on the clinical scenarios also. So to introduce this subject, uh, midlife is the period generally considered from 40 to 60, and there is shift of identity that sometimes affect the middle-aged adults. So this is the actually halfway point of life where people tend to re-evaluate their lives and confront their own mortality. So it has to be seen that how it affects the relationship and their careers and everything. Then sexual function is an important component of quality of life for women. So midlife poses a number of challenges to optimal sexual function and intimacy for women. Sexual function is closely correlated with overall well-being and relationship satisfaction. Looking to the incidence of this problem, at least 45% of midlife women are suffering from the sexual issues. And female, one thing what is true that female sexual dysfunctions are remaining under recognized and under treated by the healthcare providers like us. So it's our duty to address these situations, address these issues, so as to give proper guidance to the society. So for this, we have to understand first what is meant by normal sexual function. It is nothing but the complex interplay of physical, emotional, and psychological factors between the couple or the partners. And sexual response cycle is the fundamental interplay between the mind and the body. These are the gross definitions. Then what are the phases of sexual response cycle? We will just understand in short about the sexual response cycle, what are the phases, and what are the sexual disorders. There are main 4 phases of sexual response cycle, namely the desire, arousal, intromission, and orgasm. And according to these phases, female sexual dysfunctions are divided into desire disorders, arousal disorders, orgasmic disorders, and sexual pain disorders. This is the Master and Johnson's linear model of sexual response cycle. And this is the Rosemary Basson's non-linear model of sexual response cycle. We will not go into the details of this. So let us discuss one by one. So my first question is very simple. Which factors affect the sexual function? Which factors affect the normal sexual function? Yes. Dr. Reena ma'am, can you take this?
Normally the hormonal changes are the effect, but in the in the postmenopausal females, when the patient become postmenopausal, they have less of estrogens and hormones. The patient has vaginal atrophy, and then it affects the sexual desire, like what Dr. Apurva has been saying. And whenever the patient is sick, whenever the patient is having any disease, whether it's a medical disorder or carcinoma or any stress factor, even a simple UTI can affect her
Okay.
sexual
These are the
desires.
biological factors. Then some medical problems.
Yeah, and some drugs also. Some drugs also they can also cause affect the sexual desires, like
Yes, medications
benzodiazepines
can
and
affect.
medications,
Then
opiates, and cancer drugs also.
yes, many antihypertensives or many drugs affect. Then
Yes, there are many drugs
psychosocial
and
factors are also there.
yes.
Depression, anxiety, some stressors or trauma, particularly the past sexual trauma, that can affect the sexual function. Then interpersonal factors are there, positive relationship aspects. Then there may be any loss of a partner or due to the aging also. These are the symptoms of menopause. Just Dr. Apurva has also covered what changes occur in the menopause. We will not repeat again. Then how sexual dysfunction affects the quality of life. Everyone agrees that sexual dysfunction definitely affect the quality of life of human. Then how it affects? Yes, anyone? Other than Dr. Reshmi Singh is there, Dr. Sudha ma'am.
We can take Supriya madam, Dr. Supriya Jaishwal's expert input on
Good
this.
morning.
Yes,
Yes,
Sudha ma'am. Yeah, please.
sexual function affects quality of life because it causes depression, anxiety, and low esteem, and there is a disturbed relationship with the partner. And if the patient is in the early 40s or premenopausal age, and she might face infertility, and there is an adverse effect on the male partner itself, that erectile dysfunction, extramarital relationship, that may cause the social disruption. So this has definitely affect the social life, emotional life, and uh, these things are very important, right?
Yes, ma'am, very true. Mainly the marital disharmony is there, interpersonal relations get disturbed, and again the subsequent problems uh, rises, and which can affect on male also. That is again very important. Female sexual dysfunction can affect the male also. Is there any, Supriya ma'am? Supriya ma'am, do you want to say anything? Okay. This is the classification of female sexual dysfunctions. The old criteria was as per the DSM-4 criteria, that was the old classification, and DSM-5 criteria is the latest classification. I will just highlight in short. In older classification, female sexual dysfunctions were having 4 types: sexual desire disorders, arousal disorders, orgasmic disorders, and sexual pain disorders. So what has changed in the DSM-5? That is, sexual desire and arousal disorders are clubbed together into sexual interest arousal disorder, and orgasmic disorder is kept same, and sexual pain disorders, which were dyspareunia and vaginismus, these are clubbed into single umbrella, that is the genitopelvic pain penetration disorder. So this is the classification which is followed. First is the female sexual interest arousal disorder. We will discuss in very short. That means there is any problem in the interest and arousal, that is persistent or recurrent loss of desire in sexual activity, sexual thoughts, and sexual stimulation, which causes significant distress in the woman. That is called interest arousal disorder. Then there are some criterias to diagnose or confirm that this is the female sexual interest arousal disorder. Which are these criterias? Yes, anyone can take the question.
So there are characteristics which, I mean, out of 6 of these criteria, 3 criteria should be present in the couple, in the
Yes.
patient. I mean, there should be absent or decreased sexual interest and decreased erotic thoughts or fantasies. And apart from that, there can be, out of these 4, there should be 2, I think, at least, absent or decreased initiation of sexual activity or responsiveness to a partner's attempts to initiate it, absent or decreased excitement and pleasure during sexual activity, decreased arousal in response to sexual cues, and decreased sensation during sexual activity, whether it is genital or non-genital. It can be situational or generalized.
Okay. So out of these
Out of
6,
these 6, 3 should be present.
3 must be present to diagnose. And to make any diagnosis of any sexual disorder,
Yes,
this
they should be present for at least 6 months, and
yes.
and there should be stress visible in the partners.
Yes, there should be significant
Yes,
distress between
yes,
their
partners.
relationship, and this disorder should be experienced at least 75 to 100% of the time. These are the criteria applicable for any sexual disorder.
Okay.
Uh, Prerna, can you take this?
Yes, yes, yes. Thank you, esteemed panelists, for this very insightful perspectives on midlife crisis dysfunctions. And so we have this evaluation of female sexual disorders where there's a implicit model. We have permission, limited information, specific suggestions, and intensive therapy. Next slide, please. Next slide, please. So recognizing the underlying conditions, we just want to know from our panelists what the defining criterias and types of female orgasmic disorders. Dr. Reshmi Singh, we haven't heard you from quite a while.
Yeah.
So recognizing underlying contributions to the reduced desire. Yeah, please.
Thank you so much, Madan sir and Dr. Prerna. For diagnosis of orgasmic disorders, it is basically clinical, and Dr. Apurva, I think, sir has highlighted many things in that. So in here, it would be delayed, infrequent, or absent orgasm, which is markedly decreased, or it could be distress or interpersonal or interpersonal problems due to orgasmic dysfunction, or there are no other disorders or symptoms that are which could be exclusively accountable for this, and the symptoms should be present for more than 6 months. So these can be the criteria for female orgasmic disorders.
Dr. Sudha Jha, madam, Dr. Reena, madam, you want to add on something? Because we have the
Yeah,
types of primary anorgasmia, which had never had an organism, the secondary anorgasmia, which is they used to have an orgasm, but now they have difficulty reaching climax, then situational and generalized. Can you add something to this, madam?
They can be also situational
Dr. Reena,
anorgasmia. Yeah.
Yes, yes. So what
So
are the
they are
causes of
receiving
painful
orgasms.
sexual act? Yes, madam, please. Rashmi,
Yeah,
madam, you're saying something.
painful sexual disorders could be because of sometimes it could be classified into entry pain, which could be due to vaginismus or less lubrication or any trauma. It could be deep due to certain gynecological disorders like endometriosis or like posterior fibroid or previous surgeries, or it could be due to emotional factors like a history of sexual assault before or some other psychosocial issues the woman must have faced in past.
Very well taken, madam. Sudhaja, madam, and Reena, madam, you want to add on to something on vaginismus?
Yes, vaginismus is a condition when the woman is not able to tolerate the penetration in the vagina. It is due to the involuntary tightening of the pelvic floor muscle. Initially, the definition was recurrent or persistent involuntary spasm or constriction of the musculature around the vaginal outlet on the outer third of the vagina that interfere with the vaginal penetration. But recent definition is that the persistent or recurrent difficulty of a woman to allow the vaginal entry of the penis or a finger or any object despite the woman wishes it to be. So this is the recent international definition of vaginismus.
Very well taken, madam. So, based on the Lamont classification of vaginismus, it is based on patient's history and behavior during a gynecological examination, where we have grade 2, grade 1, grade 2, grade 3, grade 4, and grade 5. As per the indicating mildest forms to the most severe form of vaginismus, where in grade 5 we have a pasic attack. Another a grade of vaginismus where the patients with grade 5 vaginismus manifested with visceral responses such as crying, shaking, trembling, sweating, hyperventilating, and experiencing palpitations, and even nausea and vomiting and going unconscious, wanting to jump off the table. So this is the most severe form of vaginismus we can ever encounter. Next slide, please. So how to evaluate this female sexual dysfunction cases? Dr. Reena, madam, if you can take this up.
First of all, we have to take a detailed sexual history of what is the problem with the couple, where the where the apprehension is for the sexual relationship, where the difficulties are, and what are the difficulties they are facing. And there's any whatever there is any history of any multiple sexual partners or any type of high risk behavior they are following in the couple. Is there any medical history of any psychiatric illness, any surgery, or any detailed history we have to take from the patient, her obstetric history, her gynecological history, any drugs she's been taking, any history of any sexually transmitted disorder, illnesses. And then we have to examine her per cycle examination, per vaginal examination we have to do for any endometriosis or any other gynecological cause that can be there. And if required, we have to do a ultrasound or a CT. And we can do a hormonal test to see if the patient is entering her menopause. In any case,
Thank you, madam. Ranging from history to a proper examination, we have to have a checklist of the entire sexual symptoms she's presenting with, and we have to put it into documentation in black and white, so that whenever we evaluate her next, whether we can understand the what all issues, what all layers that she has got better on. So, what effects will menopause have on sex life, Dr. Madan? You can continue from here.
Okay. Yeah. Who is taking this question? Anyone can take this question. What are the possible changes? I think Dr. Apurva has discussed this.
Yeah. Well, as in menopause, the hormone levels go down. There is a huge possibility of vaginal atrophy. So most of the females do complain of discomfort or even burning, and sometimes they also complain of mild bleeding post-coital. So that kind of disinterests them from the sexual activity. And because of low hormone levels, they also have a low sexual drive initially. Then
Yes.
again, because of menopause, they have hot flushes or night sweats, which is troubling their sleep or a desire to have sexual activity. Then there is also body disfigurement because a lot of changes in water retention occurs in the body. So they have a lot of disfigurement, and there is avoidance of the, what do you say, they don't adapt to the changes of menopause. So that leads to a psychological distress amongst them. So that is also there, sir.
Okay, you're right. Actually, all these symptoms are faced by the in the perimenopausal period.
Right.
Next question is, what measures you can advise to improve the sexual health?
Yes.
What we can, as a clinician, what we can? Yes, Sudha ma'am.
Tender care, love, and understanding is the major thing we can do. And there should be very active things. We should do morning exercise, aerobics, yoga, weight, of course, because weight is very important, and pranayam. So all these will help in the uplifting the mental, physical health, and all will definitely add to improve the situation. Smoking, definitely no. Avoid the drug and alcohol. And this is very important question. Have sex more often. Either use it or it will not work. So if often sex, that will include the um, improve the blood supply of the uterine and vagina, and that will decrease the dryness and improve the sexual functions, and allow time to become more time to become aroused during the sex. Moisturization should be done to protect tissue and make sex more comfortable. Pelvic floor exercise is must, that will increase the strength of the pelvic muscles as well as the blood circulation, and more blood flow to the vagina, and that will make the muscle more strong for the orgasm. Avoid the product that irritate the vagina, the foreign body, bubble bath, any chemical. These should not be given, and any chemical we should be used, we should consult the doctor. Self medication should be discouraged.
Yes, you are very right. There are so many.
And sleep is also very important. A 7 hours
Yes.
sleep is must. At this age, 2.5 थिंग अढ़ाई चीज सुखदायक होते हैं. एक है कि निरोगी काया, दूसरा है खूब अच्छा स्लीप 7 का, और हाफ में रेस्ट ऑफ द सुख. One is nirogi kaya, good physical mental health, and second is the good sleep, and third others. So
That's very, very correct, ma'am. Very correct. Yes, this is absolutely needed in this period to maintain the physical and mental health.
So the moisturization should be done 2 to 3 times per week, and lubrication should be done if it is needed before sexual act. So it will be more pleasurable. And
Yes.
vulvovaginal atrophy, genitourinary symptoms of the menopause should be taken care of.
Yes. Okay. And these are some women's top priorities. What women want? Uh, she wants a general well-being. She expects emotional reactions during the love making. Then she expects attractiveness of one's partner. Also, she expects physical response to love making. Also, she needs the adequate sexual intercourse frequency she can expect from her partner. And also, partner should be sensitive during the sexual act. And she also believes in her own and the partner's state of health also. These are women's top priorities in the life. So we have some cases we will discuss in very short. One case is the Priya. Priya, who is 50 years old, feels a strong desire for intimacy, but her partner is not interested now. And she is wondering if she is still attractive or desirable. Then, what we can do in this case? How will you give them a fruitful solution? How will you manage such a case? She is so desirous and husband is not interested. What we can advise in this case?
In this, we can advise the patient to have a one-to-one conversation with her partner, first of all, at what are the things that the partner thinks that it is lacking. Another thing is that the woman needs to be reassured that there is nothing wrong with her, and she needs to come in terms with the changes that her body is undergoing through in the period of perimenopause or menopause. Having said that, she also needs to be counseled about the top priorities that you listed just above. That she needs to take care of herself both in diet, as madam said, sleep, exercises. These should be her top priorities. That gives her the kind of mental calmness and again a reassurance in herself that can she can communicate with her partner regarding this.
Okay, then what we can take the inference from that? This is the uh, communication is the key. There should be proper and open communication between the partners so that they can solve their issues. Is there any relationship problem? What the partner feels about her? That should be openly communicated. So the solution can be taken now.
Right.
If he is having any problem, physical problem or any sexual problem, then they can work out on that. Also, they both have to maintain their physical fitness also, and most important is to take time for moving around and for sex also. They both have to take time for that from their busy schedule also. That these are the some form of solutions for that. Then one more case is there. Sarah, after her kids leave home, she is 48 years. She is feeling a mix of emotions. She is excited for this new chapter, but struggles with her new identity and the sex drive. Then how to guide? She has mix of emotions. She is somewhat disturbed. She is somewhat excited also.
First of
Now,
all, sir,
please.
she should be counseled that it is normal, and she should not be stressed about it. And I think this is normal because now she's free and her stress factor has been like caring for the kids, and she has more time for her couple, for her partner. So I mean, and obviously she should have maintained her fitness. She should be maintaining her fitness, and I think this is normal, sir, and she should be speaking with a partner for that.
Yes, again, she needs counseling that this thing is normal and she can enjoy her life very
Yes.
well. There should be better communication between the partners, and now they both are living. Kids are not there. They can enjoy their life
Yes, sir.
happily. They can discuss their problems, share their problems about the sexual desire, if anything, sexual drive, or any sexual issue, or any other stresses also. They can share to each other. Yeah, Prerna, are you there?
Yes, yes, I am here.
Yeah, are you taking this?
Yeah. So as we move on with the separate issues of revolving around menopause, there's something like the body image issue. She feels that she is more self-conscious and about her changing body. This is Kavita, who is 45, and she avoids intimacy due to feelings of insecurity and low self-esteem. So rest is an emotional connection is good, but then she feels that because of her disfigurement, maybe her husband or her partner is ignoring her. So, what do you do next about this case if she comes to you with such a problem? Reena madam,
So again, in this
Sudha
case,
madam,
first of
anybody
all,
can
we
take
have
this.
to counsel
Even we have
the
Lakshmi.
patient. First
Reena
of all,
ma'am,
again, we have to counsel her that she should be, most important thing is that she should be confident. And of course, if she's not fit, she should try to be fit. She should do her regular exercises, and most important is that she should accept her body, whatever changes are happening in her. That is very
Yes, madam.
much important. And she should not
Counseling is the
be
key.
low. She should not feel low because that is normal. These changes are normal, whatever she's having. And physical fitness is key to the solution.
Yes, madam. Counseling is the key, but our motto of putting this particular case here was that we, as care providers, if she comes with a feeling of disfigurement to us, then we need to tell her that you are beautiful and you will
Yes.
stay beautiful, and you will definitely age gracefully, and so that she gets that confidence in her, and then she can face her partner in a more confident manner. So that is it. We can have the next case, Dr. Madan. So the relationship shift is also a very pertinent part of menopausal crisis, midlife crisis, where after 20 years of marriage, this girl Ritu, who is 52, realizes she's not getting the emotional connection she craves for, and she's questioning her desires and wondering if it's time for a change. So she's wanting to find out relationship shift, like she might be finding out some sort of sexual desire fulfillment in one of her partners who is not her life partner, or in one of her maybe somebody from the colleague end, or somebody from a very good friend of a far and relative. So this is, what is your opinion regarding this relationship shifts that she might end up into having in at this age, at the age of 52? Can we expect such relationship shifts? Dr. Sudha, if you are there, and Dr. Reshmi Singh.
We can, it's especially in the current scenarios or in the cases of perimenopause, such what do you call, questions can come to her mind that she is expecting a change, or she's not having that kind of connection. Again, the part of communication and effective communication with the partner comes into role here. And she needs to speak to her partner and her counselor or doctors, as we healthcare providers. She needs to speak her mind out, that what she is thinking, and we should be able to tell her that this is a normal part, and maybe she does not need to dive into other options at this age or at this condition, basically. Yeah, not the age, but at this condition. But
Yes.
this is a normal psychological upset or up and down that is happening to her, and we can just talk it out with her and her partner on this.
So we should discourage her to have relationship shifts. She can definitely feel insecure in this at this age with an emotional loss of emotional connection. But all she needs to
Right.
is to speak out and connect with her partner regarding this and solve the matter out, rather than diving into as per you have already said. So the libido dip is also a very important concern for midlife females, because they have this particular female who is 55. She has hit her menopause and she's experiencing low libido and discomfort during sex. As Dr. Apurba has mentioned in his entire presentation today, she's worried that this will affect her relationship with her partner, because she's already, whenever her partner comes to her, she denies. So how do you go about it, Dr. Sudha madam?
Yes, this is a normal physiological phenomena, and it is due to her hormonal change. We should do a proper counseling, and it will not definitely not affect her relationship, because with some exercise, some counseling, and open talk with the partner, and this can be solved very easily. Nothing to worry about. We should counsel. Counsel is the main part.
So
That is the
our motto
normal.
of putting this particular case is
Here
that
again, I think
and
tender, loving,
And
caring.
any
yes,
pathological things, it should be
yes,
stopped. If any pathology is in, that should be treated.
yes.
Actually, counseling plays a very important role in this, as we many of us run menopause clinic, and we should give her proper education. What is menopause? What happens in menopause? What are the changes in menopause in body in every aspect? And also menopause affect the sexual desire, orgasm, and sexual relations. So she is worried, but we have to address her properly because she is worried about her relationship, and we should assure her that there are treatment modalities available for this. This is happening due to the low estrogen, and we have the medicines which can take care her symptoms, and she has not to worry about her relationship. Just maintain a healthy relationship, healthy communication, and we can treat her for her menopausal symptoms.
Yes, we have to assure that this libido dip is universal rather than being subjective. So we can definitely take care of that, and she can move ahead with a good relationship in the years to come.
Can
So
offer
can we
her
have
with the
yes,
basket of
somebody?
treatment that Dr. Apurva sir has already discussed. He has discussed a lot about the variety of treatment that can be offered to the patients here.
Yes,
So we
yes,
can
same.
give her a basket of
But
treatment here that we can help you out here.
yes, in this case, psychological support to her is very much important. That we
Right,
have
sir.
to give by us or any counselor.
And we can add medicine also.
Yeah.
Yeah.
Prerna?
So this is the exploration phase that she is in her 50s. She's rediscovering herself, Leela, who is 50, and she is curious about new experiences and connections. This is somewhere related to the previous relationship shift question, but she's exploring new options. They're exploring about new connections and experiences, but she's nervous about her judgment. So how do you guide it? Is it good to explore at this age, or is it okay to have whatever she has to be satisfied with it?
She can definitely explore. She has to overcome that trauma of the, for whatever reason she was divorced, she has to, that trauma of the previous married life or thing, and because of that she is having that prerequisitions of reservations about herself. So it is no harm that she's exploring and she's questioning herself about it, and she's ready to explore. I think it is okay if we counsel her about the things that her body is having changes, and also the hormonal changes or shift, and the psychological changes that are coming with it. So it is always good if she can find a space where she feels that she belongs. So
She has come to your opinion asking about your judgment. Should I go ahead or not? Then how we can guide her?
She
It,
can go ahead, but she should take precaution for sexual transmitted infection.
first thing is
Condom, barrier,
important
and all
is
she should use.
we should be non-judgmental. She has
right.
each and every right to go ahead in any, but as a doctor we should advise that she should follow the safe sexual practices. She can enjoy her life. She has every right to enjoy her life, right? But she should take the safety precautions that we can, as a doctor, we should advise.
Should always use barrier contraceptives.
Yeah. That is our job to advise about
We
this.
can move on to the last one.
Last one.
Yeah, this was
Dr.
the last.
Madan.
This was the last. Now we are at the end of the session. As per what we can give take-home messages from
Before
this
the
is,
take-home message, I am Dr. Sudha Jha from Sitamarhi, Bihar, birthplace of Sita. I invite all of you after 1 to 2 years, because our very big temple of Sita is just to be completed after 1.5 years. So all of you are welcome to my place, birthplace of Sita.
Now, is this the first
Okay.
only Sita temple? Is the first only Sita temple? Because otherwise,
Actually,
Sita is always with Ram, no?
this is the birthplace of Sita.
Okay.
वहाँ से सीता प्रकट हुई थी, प्रकट स्थल.
Okay.
Okay.
और जनकपुर is the place where she was married to Rama. Please,
Okay. We will surely visit.
I am
So
saying whether
I-
this is the first temple where
I mean, this is the
Sita
only
is only
temple of
worshipped.
Sita.
No, this is not the first temple, but this is the birthplace.
Yes.
Okay.
Arpita ma'am is there.
Modi and Amit Shah is taking a special care for that. This temple should be more big than the Ayodhya temple. So all of you are.
Okay.
Wow, that
Is
then
it?
then we
Very
will
nice.
definitely
Invite
visit,
all of
ma'am.
Definitely come. Ma'am.
We'll definitely visit.
Okay.
One take-home message from all our esteemed panelists.
Yes.
Reena madam, please.
Arpita
I
ma'am,
would say that-
you also please, give a single line take home message.
The most important, sir, is being physically active and being healthy.
Okay. Sudha ma'am.
Pelvic floor exercise is must.
Yes.
Not only for the sexual matter, but for the to prevent us from the fall.
I think right side is very important. Open communication, improve intimacy with your partner, and take some time for sex. That is very important. We as obstetricians are so busy in our practice. If the practice is loaded, like Dr. Prerna, then it becomes very difficult.
The social media is also taking a lot of time.
Yeah.
Definitely.
Conferences.
Counseling sessions or specialized counselors are available, and that has to be addressed well. And it is a skill to manage our stress, our work, our anxiety. That is very much important because our life is so stressful. Our professional stress is there, personal, family, social, financial. Every stress comes in a doctor's life. So, thank you so much for the entire esteemed panel.
we can conclude, Dr. Madan.
Yes. Well, thank you so much, all the esteemed panelists, experts, Dr. Supriya Jaiswal ma'am, and all the panelists for. Yes, anyone want to say?
Dr. Madan?
Yes, ma'am.
I want to say that we never disrespect the desire of a lady because I have taken interview that the desire remains even in a lady of 70, 72 years. And I have seen, I criticized it very badly. I have seen an operation, I won't name because they're very famous surgeons. They did Leaford's operation in a patient of.
Madam, voice is breaking.
Ma'am's network is poor. She has logged off. So every good thing has to come to a conclusion, and we are. It's really customary to extend our vote of gratitude, and we thank each and every person who joined in to make this for the success. So, Arpita ma'am, you are there again. Okay, madam. Madam, please. Madam, we can't hear you.
First of all, congratulations, Prerna, you have won. I mean, I think you won the election, right? Prerna, right?